We'll start now. Thank you, everyone, for joining in. Thank you so much for PUSEN for organizing this webinar, which is very apt because it's on modern-day flexible ureteroscopy and the technological innovations that go with it, including, of course, the new suction scope. I've got a very esteemed panel here who have all done a lot of work in urology. Dr. Vineet Gauhar is from NG Teng Feng General Hospital in Singapore. Dr. Wang Kunji is from West China Hospital in China. And Dr. Silvia Peretti is from San Rafael Hospital in Italy. And I am from University Hospital Southampton in UK. So together, we'll give you a very broad, but hopefully very cutting-edge overview of modern-day flexible ureteroscopy and the innovations. And there are 4 talks, and the last talk is about a case discussion with some videos again on suction. So without wasting any further time, I'll hand over to my good friend Sylvia to start off with the laser talk. Sylvia, over to you. Thank you.
So, dear Professor Somani, thank you very much for this kind introduction. Dear colleagues, good afternoon. It's a great pleasure and honor for me to join this interesting meeting. Before starting, I would like to thank PUSEN for organizing this meeting about a very hot topics in endourology. I'm going to share my slides. Okay, only just a moment. Can you see my slides?
Yes, very well.
Okay, perfect. So let's talk about laser and optimal settings and to share tips and tricks about laser. So we know that now we have several laser technologies. We have a Olmuyag laser. We have a TFL laser. Why I cannot TFL laser, and also the newborn is the pulse Thulium-Yag laser. So when we talk about laser, we have to keep in mind the laser parameters. So we talk about energy, that is measured in joule, frequency in hertz, and the pulse duration in milliseconds. And the energy is what breaks the stone. And the higher is the energy, the greater is the ablative effect. And when we talk about energy, is in joule and is what multiplies seconds. So the pulse energy is the peak power multiplied pulse.
Я на місці поки.
Sorry?
Пізніше трошки піду.
Sorry, can we ask the audience to please mute yourselves? Dr. Oleg, can you please mute yourself?
No.
Okay, so the frequency only speed ups the delivery of energy, but does not break the stone. And when we talk about laser, we have to think about the frequency, and also the pulse is emitted in a very short time, and then we have a silence between the 2 peaks. And the pulse duration is the period of time in which a certain amount of power is delivered at each pulse. And then when we talk about Olmuyag laser, we have also advanced pulse modulation. We have the vapor tunnel mode that is a super long pulse, and is very useful for the limited retropulsion and the fine stone ablation. And so when we compare in the short pulse of the Olmuyag laser with the long pulse, you see that the peak power of the short pulse is very high, and the duration of the pulse is very short. So we have the same amount of energy, but the peak power is completely different. When we talk about a long pulse, the peak power is lower, and the emission of the pulse is longer. So if we compare in the lab the short pulse with the long pulse, and in particular the vapor tunnel, you see that with the short pulse we have a very high movements of the stone, and with the long pulse we can obtain dust of the stone with really fine movements and less retropulsion. So just in the reality, you see that when you use the long pulse, you have a very good dusting of the stone. And we have also the virtual basket that is just the same concept of the MOSES technology that we will see later on. And we have a double pulse emission that combines a low retropulsion with a fragment suction effect. So we have the first peak pulse and the second peak pulse. And the second peak is emitted at the maximum expansion of the first bubble before the collapse. So if we compare the short pulse with the virtual basket at the same energy, you see that with the virtual basket we have less retropulsion, and also the ablation is finer. Also the virtual basket is good for performing the popcorning, as you can see also in reality, but also in the lab, in order to reduce the size of the fragments that we obtain. We also studied in the lab the TFL compared to the virtual basket, and we saw that the ablation rate of the TFL is higher than the Olmio-Yag, but for some settings, the virtual basket is comparable to the TFL. I told you that the MOSES technology is just the same, and you can see in the reality, in the clinical settings, that if we have a MOSES technology compared to the regular mode, we have finer ablation and less retropulsion with MOSES technology. So we can modulate also the MOSES distance and the MOSES contact, and it has been demonstrated that the MOSES distance is better in the clinical settings if you stay just 1 millimeter away from the stone that you are treating. And then we have also the TFL, and it has been demonstrated that the TFL in the lab and in clinical settings is better for dusting. In the lab, according also to this paper of the group of Professor Traxler, according to the features of these two different technologies, we have a less penetration depth with the TFL. So we have also less damage of the mucosa when we treat the stone, and we touch the mucosa in case of breathing, and we don't have the contact with the stone and with the mucosa, and we can modulate also the pulse and energy, and we can reach the same joule, but we can start from a very low energy, and we can reach also very high frequency. But the question is, do we need this very high frequency during our flexible ureteroscopy? In the lab, it has been demonstrated that it was very useful, but in the clinical settings, I will show you later that is not useful. And the short pulse of the TFL is longer than the long pulse of the Olmio-Yag laser. And also what is really interesting, that the laser fiber sites that we can use with the TFL are smaller than the laser fiber that we use with the Olmio-Yag. So it is interesting. Why? Because we on the market now we have the 150 microns laser fiber, and now I know that 100 microns are laser fibers are coming to the market as well, and is useful because in the working channel we have more space for the irrigation, but for the suction as well. So we will see later the meaning of the suction, and also from the technical features and the ergonomic, for sure TFL is better than the Olmio-Yag laser. Is lighter, and also you can plug in to the normal Schuko that we have also at home. And if you compare the peak power of the Olmio-Yag laser with the TFL, the peak power of the TFL is lower and is longer, the amount of time that in which the pulse is emitted is longer compared to the Olmi-Yak laser. And it is important in the clinical settings. Why? Because if we want to have more dusting and less retropulsion and the size of the fragments smaller, we need to work with the TFL. So as Professor Somani showed in this review in the lab, it is fantastic, the TFL compared to the Olmi-Yak laser. And also it has been demonstrated that the TFL is able to disintegrate all the urinary stone composition except for the calcium oxalate monohydrate carbapatite, which conserve their initial characteristics. And but which is the best laser for lithotripsy? So we wrote this editorial, and we said that maybe the truth is in the middle, because one thing is the lab, one thing is the reality, and TFL is almost a laser, a contact laser. So in the reality, we have the breathing movements of the patient, we have a displacement of the fragments inside the kidney. With the irrigation, we have a lot of dust. We have also some minor bleeding that can impair the visibility of the inside the kidney. So it's not possible every time to be in touch or very close to the stone. And so this is the reason why maybe we didn't have the same the same result that we obtain in the lab. By the way, it has been demonstrated in this first randomized study published in European Urology that the TFL compared to the Olmi-Yak laser is better in terms of stone-free rate and also the mean laser surgical time. But the question is, these authors compare the low power Olmi laser to the TFL, and so is like comparing a Tesla Roadster with a Fiat Panda instead of with a Ferrari to demonstrate the superiority of an electric engine over thermic one. So it has been published also this other paper in Journal of Urology that in which the authors compare the TFL with the high power Olmi-Yak laser, and they showed that there is no significant clinical advantage of TFL over the Olmi-Yak in terms of time, stone-free rate, and complication. And also, my friends Vinet Bhaskar and also Daniele Castellani published this other interesting paper on TFL versus Olmi-Yak laser, and is a retrospective study, multi-center study with more than 2,000 patients enrolled. And they show that the TFL is better in terms of stone-free rate compared to the Olmi-Yak laser. And also the basket extraction of the stone is lower for TFL, the TFL group compared to the Olmi-Yak laser. The only thing that I can say, and they state, the authors in the paper, is that the postoperative imaging is not homogeneous, and the CT scan, the CT scan is really is not request in the postoperative course in all patients, so it's difficult to compare the results. By the way, they observe also that with the TFL they show higher postoperative sepsis, really strange and interesting at the same time. Maybe the postoperative sepsis is multifactorial, and fewer patients in the TFL group had larger ureter sheet. What is really interesting is that more patients had a reusable scope. I'm sure I'm a big supporter of the single-use ureteroscope, and so this is when I read this paragraph in the paper. Really, I was really happy to see these results. And so, by the way, they demonstrated that TFL is superior compared to the Olmi-Uriag laser. So, which is the best setting? No, we don't know. As Professor Traxer said, we need to establish the best settings for the TFL, for the laser technologies. And so we have to start very low energy, very low frequency, and then to increase and to modulate our laser settings according to the clinical scenario that we have in front of us. So with the TFL, we can treat very well soft stones. We can treat also calcium oxalate, monohydrate stone. Even though I'm not a big supporter of the TFL for the treatment of stones, I'm super happy with the tumor. I'm telling you this because, in my opinion, the TFL, the peak power of the TFL is too low. It's still too low, and we need to increase in the future the peak power of the TFL in order to have better results. By the way, we have to keep in mind that the temperature inside the kidney can increase when we use the TFL, and it has been demonstrated that the TFL can develop a higher intrarenal temperature compared to the Olmi-Uriag laser. And as Professor Traxer said, maybe for the urethral stone, the total power should be 10-15 maximum, and for the renal stone, 20-25 watts. Also because we are witnessing a higher complication rate compared to the past. I mean, we have more urethral stenosis in our patients that we treat with the stones, because with stones and these new laser technologies. And maybe we have to keep in mind that the laser can be dangerous when we don't use really good settings in treating our stone patients. And so we have to perform an intermittent laser activity with continuous irrigation flow. We have to balance between irrigation and power, and also suction as well. And so we have to use room temperature cool irrigation fluid, and not anymore the warm irrigation that we use in the past. So some drawbacks of the TFL, we can have some flashing, so we have to use the short pulse length.
Sorry, Sylvia, one more minute, Sylvia, sorry.
Yeah.
Thank you.
Tell me when I carry on.
Oh, yeah, please carry on. Sorry, one more minute. Sorry,
Okay.
please carry on.
Okay. So, and we have to use also the low energy. And we can have also the carbonization of the stone if we don't use optimal settings for the TFL. And again, we have to use the short pulse length and low energy. And what is really important is that we can produce a very good dust. We can perform a very good dusting of the stone. The problem is that we have so much dust sometimes inside the kidney that the visibility could be impaired, and so this action could be really the solution, the the success of the flexible ureteroscopy when we have so much dust inside the kidney, and also some microfragments could be just below the dust. But if I ask you, we have a very good dusting in the first video and the second video, which is the TFL. We cannot say honestly that with the TFL and the Olmuyag laser we obtain different pulverization of the stone. Also with the Olmuyag laser, for sure you can have a very good results, still good results. So both laser technology are safe and highly effective, and surgeon preference is the best approach when selecting one or the other. Just few words with the new laser technology. I'm very happy with this new technology. Is the Ureteroscopy pulse laser that I think is a good compromise between the Olmuyag laser and the TFL, because the peak power, as you can see, is higher than the TFL and is lower than the Olmuyag laser. It has been published, the first series on Olmuyag pulse laser for stones. As you can see, the stone free rate is very good, and also the safety profile is good as well. So we can, I want to share with you some videos on stone dusting and popcorning that you can obtain with the Olmuyag pulse laser. And again, you have a lot of dust. So suction devices, flexible ureteroscope 7.5 with suction by PUSEN could be really the solution. And what is really good, in my opinion, for the Olmuyag pulse laser is that it is a more versatile laser, because you can obtain dusting, popcorning, but also you can fragment stones, and you can use also this laser for mini perk. I know that some colleagues perform dusting also in mini perk, but honestly speaking, I prefer to fragment the stone and to evacuate the fragments through the ampla sheet thanks to the vacuum cleaner effect. So in conclusion, I would say that the Olmuyag laser, the Pulse One, is could be in the space that is in between the Olmuyag laser and the TFL laser. And before finishing, I want to share with you this very important paper in order to standardize all the terms that we use when we publish about papers about laser, in order to standardize the literature. Is very interesting in my opinion. And in conclusion, the Olmuyag laser with its advanced pulse modulation provides very good results in terms of stone ablation rate, safety, and procedural time. TFL is relatively new laser, but is very promising as well. And the Olmuyag is in its infancy, but it could be a good middle ground between Olmuyag laser and TFL. For sure, is a new technology that needs to be investigated, and more randomized clinical studies are needed to compare the TFL with the Olmuyag laser and with the new pulse Olmuyag laser in terms of effectiveness, safety, and also in long-term follow-up. Thank you very much for your attention.
That is great, Sylvia. Thank you so much for your talk and for giving us a very in-depth analysis of different types of lasers. With that, we'll move on to the next talk. And over to you, Professor Wang.
Okay, thank you, Professor Somali. It's my great pleasure to join this meeting. I just want to share some of our little experience. I use a small scope and with suction sheaths to improve the immediate stone clear rate. Actually, the development of flexible ureteroscope is very quick. But if we're looking forward, what we should do in the future, I think we should think about maybe we can immediately clean every stone fragment by using a flexible ureteroscope. Why we think about this is because now we have the much better ureteroscope, which we can reach almost everywhere with the kidney, just like a PUSEN flexible ureteroscope, with a more longer bending section and the very clever design of the bending area, which can have the 318-degree bending, which help us almost can easily go everywhere within the kidney. Because we can go everywhere, we need to think about we should clear every stone immediately, just like the PCNL. Why we need to clear the stone fragment immediately is now the evidence told us no matter what kind of size of the fragment, if they stay in the kidney, at the end there will be the clinical stone. And even you use the dusting strategy, breaking the stone in very, very small fragment, but if they stay in the kidney, they will progress into the clinical stone disease. So the concept of clinically insignificant residual stone maybe is not so correct. We should clear every stone we can see. But how we can do that? I think we need to think about 3 different things. The first, the first thing we think we should have a more small ureteroscope. As we know, the small ureteroscope is very is a key point with the safety. But when we can get the great safety, can we use the small scope to give us much higher immediate stone clearance rate? Just like we just get this 7.5 French flexible ureteroscope. We tested the safety in our lab by using this 3D print model of kidney. We can see even in the small sheets, 10 French small sheets, by using 7.5 flexible scope, we still can get very safety pressure within the kidney. But if you use the normal size flexible ureteroscope, you cannot keep the pressure within the kidney in the safe area. But another interesting we found is if you use more small flexible ureteroscope, you can safety, but you can have a more higher flow rate within the kidney, and they come in very quickly, and they also can come out very quickly. That's make us this high flow rate maybe is very helpful to us to bring much more small fragment more efficiently. Is that true? Okay, next we can see if you use this small flexible ureteroscope. Of course, we should have a much better laser which can help us broken the stone into a much small fragment, which can help us to wash this fragment with a high flow rate. Just like we use the Moses laser, we can say with the suction sheath, we use a small scope. When you broken stone, you can say almost all fragment is going out with a flow rate, with a flow field. And if even we did not use the suction sheath, just use the thin flexible ureteroscope, we also can see many fragment is washed out because the space is much bigger and the water coming and come out speed is very high. just like this video showed us. And then interesting is when we use a very small ureteroscope, we just sometimes we just move the scope in and out. We can wash out almost many fragment stay in the kidney, just like this, come in and come out. You can see with the water flow, the fragment is washed out. So that is a very important key effect of the small flexible scope. Just we can say many stone is washed out. So I think the better laser also we should have the very small flexible scope, but that's still not enough because the flow rate is just around the tip of your flexible scope. But when you come into the kidney, there are large space. In that area, we cannot try to wash out a stone just like within the ureter. So we did some new tools. So fortunately, we now have the bendable suction ureter sheath, which can go with our scope, just like this. When the suction sheath can go with our scope, so we can use this very magic effect to broken and move the fragment in the same time. Just like this video showed us, we have the very small flexible ureteroscope, and we can see the tips and the body of this scope is very, very small. If we compare with the unflexible scope, we can see it's very, very small scope. Then with the normal, which the tip is unbendable suction sheath, we can see the traditional unbendable suction sheath, they cannot move within the ureter. If you try to move, they will damage the tissues. So you have to stay your suction sheath just in area of UPJ. Then you try to use a good laser to poke stone into a small fragment. But at the end, you found the large some fragment in the upper pole, middle pole, they cannot wash out by you move your scope and try to even change the position of your patient. So you can say we change to the bendable suction sheath, which is very soft tip, which helps it can move within the ureter and did not damage the tissue. Now we can see the suction sheath tip can go with us scope and use the suction effect. We can very accurate go to everywhere and wash out the stone fragment just as you want. So with a good laser and very small flexible ureteroscope and a bendable suction sheath, now we almost can immediately clear every stone fragment. So our opinion is that try to reach as high as impossible immediate stone clear rate is our goal of flexible ureter scopes lithotripsy. If you try to do that, you maybe have to have a good small flexible ureteroscope and have a good laser and combine with a bendable ureteroscope sheath, which is very helpful for us to reach that goal. Thank you for your attention. Thank you very much.
Thank you so much, Dr. Wang. That was great insight into how the suction works. With that, it leads us very nicely into the next topic, which is again the role of suction access sheets, which Dr. Vineet, who has published extensively and is doing a lot of work in this area. Vineet, over to you.
Okay, yeah, thank you very much, Professor Bhaskar, Dr. Sylvia, Dr. Wong, and PUSEN. You all have put together a really beautiful program. I'm sure there's a bit of overlap. So I was given the task to explain to the audience the role of suction ureteral access sheath. Part of my work has been easily done, but it's not just an accessory. And I'm just going to try to convince you that this is more than just another ureteroscopy accessory. So my topic will cover some experimental, clinical, as well as some personal experience, and also show you the advances that we have made, because we have the sheath in practice almost for 2 years now. And these are some of my disclosures. So most importantly, when we talk about suction, I think you've understood by now what it is. You probably are wondering why we need it, and you definitely want to know how to use it the best way. So I think in endourology, and not just RIRS alone, anything that you add suction helps to improve stone-free rates. But stone-free rate is not our prime target, is it? Does it matter to suction in endourology? Can it improve anything else? And I think this is something which I answered in 2020, that it probably will definitely improve stone-free rates. It may minimize the complications, but let's look at what evidence points today and why we need it now. Most of us are increasing our trends of RIRS. There is enough papers for that. Our PCNLs are becoming smaller. We are trying to do more and more bigger stones through smaller tracks. And that's why we need to have something to make the procedure more safe, more effective, not just for the patient, but also for the surgeon, because you really want to make sure that you can get a good stone-free rate with lower sepsis. And these are the two key factors which we'll be looking at constantly when we proceed further. We'll narrow our focus to RIRS here. We'll skip PCNL. Where are we in RIRS in the guidelines? In RIRS guidelines, we all know, and everything has been shown. Professor Sylvia has shown you, Dr. Wong has shown you, great lasers, smaller scopes, great training opportunities. So you guys are all perfect in doing RIRS. Why are you still not able to aim, or are you actually trying to aim for a zero residual fragment in each case? When we looked at this was the real reason why we looked at the Flexer registry. 6,600 patient line, 21.7 patients have residual fragments, and 50% of those go through a further intervention within 3 months. Why are we not able to get the 100% stone-free rate? So the reality check is we have a lot of information, but we are still not able to get the Mission Impossible, because all of us live in different environments. Some of us practice with access sheets, some of us practice pre-stenting, etc., etc., etc. One key point here is we all don't have a standardized imaging modality. So now let's just put a standardized imaging modality, CT scan. Can we get a zero residual fragment, and can suction help in that? We have understood that we have more powerful lasers, much finer dusting. So theoretically, the dust should result in better stone-free rates. But if you look at all this information that we have, it doesn't matter whether you dust or whether you still remove, you still are not able to achieve 100% stone-free rate. So the laser alone is not your useful accessory. How you use it has all been explained. It's definitely important. And what we have already seen is that when you have such fine dust, it causes a snow globe effect. It hides the bigger pieces. It obscures the visions. You really can't move on to bigger stones. And all this settles in the dependent calyces. So the only way, apart from all that, the only problems apart from all that is pressure, temperature, vision, sepsis, and then, of course, the lower pole. It seems to be such a challenge to even do RIRS, and can we improve it? I think so that you can. And personally, I believe that the way ahead for this, okay, this is not moving. Yeah. So I'll show you in the next couple of slides how and what are the main key issues that we'll be tackling with suction. First of all, of course, pressure. Everybody knows that if you have too much pressure, and this is a beautiful experiment which shows you the methylene blue which goes all the way out, which we don't really often look for pyelonephritis, pericapsular collections, etc. If you have higher pressure inside, you are bound to have complications. And that is the basic reason why RIRS is suddenly taking a backseat in some places, because they're scared. The other problem is, of course, when this gets into infected stones, get into the blood, you have bacteremia, you have sepsis. And we've realized that 30 millimeter pressure is a good point to be at. If you can get the pressure lower than that, no matter what you use, and that is simply done by using an access sheet, then you're able to actually achieve the problems of sepsis. You negate the problems of sepsis. So can I just give you one solution and be bold enough to say that this accessory of a suction access sheet actually is a game changer? There's enough proof before the flexible option came where we knew that you can actually get great, it improves your surgical efficiency, lowers the operative times, higher stone-free rates, etc., etc., etc. So what we were doing at that point of time, we were basically sucking out fragments, we were mitigating the snowstorm effect, we were able to get that, but we don't have one single kidney. We have a calyceal anatomy which differs from left to right side. And the problem is we can't get to all those parts of the kidney, we can't get the fragments out, and we definitely can't aspirate all the dust, even though we are putting the access sheath inside the kidney. So we move from keeping it in the ureter, keeping it below the PUJ, keeping it across the PUJ, and still not to much avail. That's why I think, we'll skip this part, but I think we decided, why not we take the scope inside? Why can't we use the scope itself? And that gave some innovations to the concept of direct in-scope suction. Yes, you can actually aspirate a great amount of dust, as you can see over here. Looks beautiful when you take these photographs. Did a study on this to finalize how it should be done, how the procedure should be done. We could even go on to bigger stones, really get excellent stone-free rate. No. The problem was, we still, if you take the most challenging cases where you want to do a good RIRS, 2 centimeter stones, lower pole stones, you don't want to pre-stent, you don't want to use a sheath, you don't want complications. We were able to get all this with suction, but we still had 10% residual fragment. Not to forget that what I showed you, the crude mechanism of opening and closing. When companies like PUSEN came into the market, they decided, let's adapt this into the scope. Beautifully adapted, the handles changed, became more ergonomic. We got suction inside here. They actually came out with this fantastic cystonephroskop. I've been using this both antegrade and from a cystoscopy point of view. Very sick patient, very big stone, do it under sedation. I'm able to actually, and I realize that suction really works through the scope. The dust has to be really, really fine. The irrigation has to be really, really good. Those are the two critical criteria if you want to dust and aspirate through the scope. Whereas this is a technology which is still, I would say, in its developmental stage. It's here to stay. And I think the next year we probably have more information on why dust and suction through the scope is going to be the game changer. The problem is this particular beautiful paper and this slide where right now we know dust of 250 microns can be aspirated. But through the scope, if you want to get everything through this 3.6 French working channel, we need to go below 63 microns. Can that be possible? I'm just going to give you a little bit of a teaser at the end of this show. Dual channels are back. These scopes, one side goes through irrigation, one side does aspiration. So that way your scope damage is minimized. But problem is the working channels are bigger. Let's shift our focus from the scope itself and move on to what was being shown by Professor Wang, the novel flexible vacuum access sheath. I don't like the word bendable, so I call it the flexible and navigable sheath. We know for sure that this controls pressure and this improves stone-free rate. So we decided, let's study it ourselves. So we did an audit. We were looking at different kinds of prototypes. This is the setup in general, how it will be. Great, you get fantastic amount of dust, you get a fantastic amount of stope. It worked really well. What we realized is that you can actually get to the lower pole as well, but it has to be pre-stented. So most of the patients, if they're pre-stented, you can use the bigger sheets. So if you want to use the smaller sheets, which actually are the better options to use with the smaller scopes, because theoretically, when you have a smaller scope and a smaller sheet, your torquing ability is better. We realized by using a smaller sheet and a smaller scope, we are actually able to now get the scope to move along with the sheet into all the parts of the kidney actively and flexibly and passively. But I would like to draw your attention to this one single fact, part of the slide. No infections. Absolutely no infections, just a low-grade fever maybe at the time after you finish, but then no infections, no sepsis, no accessories. I didn't need a basket to remove it. No additional interventions for the patient. Fantastic. I was so confident of getting a good stone-free rate that we just put 3% of the patients were stented. We even did this in single kidney, but there's no point in 1 or 2 people doing it. Saeed and me did it. We had great results. We shared it with Dr. Bhaskar, with Dr. Taxia. They gave us inputs. We've got a great paper there. But it has to be replicated. So we published this on how you want to do this. And I would probably run through this, but pay attention to this when you buy whichever companies. There are 6 companies now making it, and there are 3 more coming out. So that's how fast it's getting popularity. Make sure that this is really, really flexible and bendable, because that is your key factor. If that can go into all parts of the calyx, you handle it just like you would do. You're going to, even the bigger stones, I would not try to confuse you by saying that we don't really need fantastic laser settings, but let me just put it simply. If you can fragment and aspirate rather than dust and aspirate, then why would you be really needing high powers and high energies? You need a good laser for dust, yes, but you probably don't need very high peak energies. So what's happening today is you were bringing your stone to your scope using all the ways that you had. Today, I think you should bring your scope or your sheet and then get a zero stone-free rate. And a zero stone-free rate is definitely possible. Now, this is a practical part where you have to learn, you'll be able to maneuver the scope in and out of your sheet, which is why I said you really need a good quality sheet. And that's how it's going to look inside when you're coiling and moving through the sheet. As you move through, you'll be seeing how your scope is going through. Now, this inside hydrophilic coating somehow in the Cleopatra and a couple of other sheets that I've used are fantastic. They've managed to really improve that, the way the scope slides through. What is equally interesting is that the tip of this scope, as you see over here, is so flexible, not just the bendable, the actual tip is collapsible. It's like leaflets. You will find no bleeding when you move it inside the calyces, even in inflamed kidneys. So it's a win-win situation. If you're careless with your laser, yes, you will have bleeding, but the sheath is not going to be the reason why it's going to bleed. And when you do this, you actually get a lot of stone fragments outside. To put it in the different ways that it's ideally supposed to be used, because I worked with the person who developed the patent for this, his name is also Professor Wong. So Cleopatra, when they patented this, they actually proposed to use this by keeping it near the stone. And what they have suggested is you dust or you fragment the stone up to you, because when you're applying suction, it doesn't retropulse. So imagine you have a stone in the upper pole and the fragments are not getting thrown out or the dust is not getting put into the other parts of the kidney. It's great because everything is concentrated in that calyx. So it's up to you, keep it here and dust, or even better, in those really thin infundibulum where you're scared the laser is going to cause damage, bring the scope inside the sheath and then you do what you have to do. That's the second way to tackle it. The third way is you finish dusting, and I would advise this because you need good irrigation. Finish dusting and then take your sheet to all the parts of the kidney that you want and then aspirate it. You need to have 120 ml of fluid going in per minute, and you need to gauge your pressure for your suction based on starting from the atmospheric pressure and increase it gradually. And don't worry when you have such high irrigation and you're increasing the atmospheric pressure. With suction, you're not causing a problem, and I'm just going to show you another video on that. And finally, last but not least here, once you have fragments and you are really, don't want to spend too much time, get all the fragments out. Okay. We have got up to 20 fragments at one time through a sheet when you apply the right amount of suction. And this is just one single, and this was a single kidney patient done under just some sedation, not even fancy anesthesia. We're able to get the entire stone. I'm really happy because I'm able to show my patient a single stage stone-free rate the next day, because we are so confident with this on table that we are able to do a CT scan the next day and show the patient, look, there's nothing left inside. I would definitely advise those who are looking to use this, and there are many people now who are starting to use this, please choose a sheet which has a good coating. Choose a slim scope. There's no debate about it. Whether you choose PUSEN or any other company, a 7.5 is excellent. When you keep the access sheet just across the PUJ, allow the kidney to distend first. Don't start moving your scope inside because you need space to move the sheet and the scope inside. You must test for the flexion outside before you start inside. I always do that. I make sure that the sheet bends very well because I want you to understand that your scope is going to be not touching the sheet tip. It's actually going to be behind the sheet. So your scope may be bending very well inside, but you have to make sure that the sheet bends very well too. So test this. You do not need a 360-degree bend, but you definitely need to have at least a 180-degree bend. And you can see over here, even when you withdraw the scope, the active and the passive flexion is so good that it nicely holds in the kidney beautifully well. Just a practical point, but this will be something which you will need to understand. And I would now allude to this beautiful experiment which showed why keeping the sheet and the scope closer, the pressure, the temperature, and the ability to generate the dust column, which because of suction is much better. So when you want to aspirate a smaller scope inside a bigger sheet, get closer to the stone dust, and then you apply the suction, works the best. So that would be another very practical point of view when you are actually applying this. If you look at it a little more closely, why is it called the vacuum cleaner? Because this actually can get rid of all these dust fragments. Excuse me. Dust fragments. You can get big pieces of the stone, which you cannot do with the traditional sheet. So We have one more very important thing that we must remember is the pressure. In the animal model, different sheets were shown with various irrigations, and that's about 120 and 126. So that's why I said you can go up to there. Just 9 or 10 millimeters of pressure inside the kidney. Forget about animals, because animals may, or even models, they may have a very resilient kidney. But if you take a beautiful study, we're doing this with our consultant, Steffi. She's a brilliant person working in Hong Kong. So we are using one of the scopes which is available over there. She's done this case, and I borrowed the slides from her. Look at the irrigation is going up. This is your cutoff 30, which I want to keep as a safety margin. As the irrigation goes up, the pressure goes up. But the minute you start lasering and suction, it drops to 15 or 15. But the minute you apply suction, it goes into negative. It's amazing because you have to go beyond 100 millimeters to get your fragments out. That's one thing we learned. What's most interesting from this is, with suction, as you're lasering, the pressure is only around 23. And once you apply a suction, which with a, at a higher pressure, it can go down to -3. I'm 100% sure at -3, you're not going to damage any part of the kidney. And this translates into less pyelonephritis, less pain, less fever. And when you start doing cases, you'll realize my patients are actually able to go without stents, and your patients will be able to go pain-free. And we actually tested this, and 4 of our surgeons, we did this in 4 countries. We started safe. We started doing a CT scan in 24 hours. Our median operative time was 65 minutes. And look at that, up to 1.5, 100% stone-free rate next day morning. We got confident. We started doing it better. For those stones which were even slightly more complex, in 4 weeks, we were able to get 100% stone-free rate. And today, now we are aiming for those PCNL kind of stones, which we are still able to get 100% stone-free rate. For the first time, we are really happy to show 100% stone-free rate. This has never been shown in any study in a single setting. That's the key, right? But look at the most important part. No sepsis, no re-intervention, or rather 3 of them, because we're just observing. So if you call that as re-intervention, we are observing. I'm only encouraging you and telling you that, maybe you would be wanting to do more and more suction, because I think there's a beautiful way in which you can challenge yourself. These are all the various stones that we are now dealing with, which we never thought we would be able to get a CT proven almost 100% stone-free rate. There are other things, as you know, there are different catheters and different everything is good in your hands if you get used to something. So I'm not saying that that's the best way that I showed you, or that's the best way that the market is there, but all the suction technologies are definitely improving stone-free rates. So much so that they started introducing them into semi-rigid scopes as well. Ureteric stones have become easy to do. And this is a brilliant thing that we were studying. It's really, really interesting. It works very well. We published this paper to show you all the technologies that are available to use. What's most interesting is they are all coming with pressure systems. So the pressure systems which were introduced by Lithoview Light may not have had significance earlier, but now they do. We're coming out with newer scope technologies where when you deflect to the lower bowl, sometimes you pull out the scope and then the sheet flips back. So now you can lock it over there. This is being studied right now. These are some of the tools that I have in my practice. Without this, I don't even venture onto the table for RIRS or PCNL. And technology continues to evolve. You can actually now disconnect it, reconnect it. You have access sheets which come as normal looking, and then you suddenly want to now make this into a suction access sheet. Very easy. Just unscrew that, connect your suction, and it works beautifully as well. All this gives you so much flexibility to tailor your surgery. And now I would bring back the point where we were talking about power, density, and Dr. Sylvia mentioned saying she's not.
Sorry, we need one more minute, Vineet, please.
Yes, please. I'm finishing in a minute. That she said that you cannot get a peak power with TFL. And we are working on this because if you have to have fine dust, I completely agree with her. You must increase your power density. What this translates into is that when you hit a laser fiber onto the stone, it should totally crack it, dust it. And can you do that with low frequencies, low energies, low wattage, so that there's no worry about temperature and pressure? It's happening. It's possible. What has this translated into when I did the experiment is from 250 microns, we've got dust now, which is 20 microns. So through the channels, through the 3.6 plugin channels, we will definitely be able to aspirate dust in the future. So I think so, and I would like to probably end my presentation over here. In 2023, as we move into 2024, 100% vision is better, pressure is better, temperature is lower, stone-free rate is better. We are definitely on the threshold of making zero fragment RIRS. We all need to learn the technique better to be able to do bigger stones. Please change your imaging modalities because a CT scan is your only absolute proof. and you can advocate using this in all of the technologies. We invite everybody who's on this webinar, and Professor Bhaskar, Professor Taxia, and a few of us. We're doing this worldwide study on suction, and we more than welcome you to participate with us. Probably that's why if you look at the internet today on Twitter or X, you definitely find a lot of activity going on the bendable and various technologies. And you're probably on the threshold where I think Professor Bhaskar will definitely get suction into the guidelines in the future. Thank you once again for your kind time and presentation.
Thank you very much, Vineet. Yes, it's an excellent presentation. Guidelines are always dependent on the evidence, and as the evidence grows, so we're very careful of introducing something new. But I'm sure it will come. With that in mind, I'm just going to start my next presentation, which is about what is hot in endourology. And I think there's a lot of things that we have already covered. Suction is definitely hot. And as a part of this, I'll mention it. This is my relevant conflict of interest. So I think there are lots of things which are hot. Training is better. Shockwave lithotripsy with burst wave and acute lithotripsy is there. Laser, we have heard from Sylvia, beautiful talk. Pressure, temperature, suction. Vineet and Dr. Wang has just mentioned about all of these aspects. Intelligent and smart small scopes. AI algorithms perhaps is going to modify the predictive values. Virtual clinics and follow-up of patients. Stone volume measurement will come in rather than single parameter of stone size, perhaps using less radiation. Let's start with the burst wave technology. I mean, there are two technologies. One is ultrasound to propulse and reposition the stone, and then burst wave lithotripsy to break and dislodge. So essentially, you can move the stone using ultrasound and then do a better targeting. And both targeting and both improving the movement allows you to get better stone free rate. Initial stages only, but hopefully there'll be more to come with this. Let's look about training. Training has really changed the way we do it, and we have standardized training. Basically, you go through an initial boot camp, and then you have the basic, intermediate, and advanced training. And as you go to the top of the pyramid with advanced training, that is done in animal models or cadavers, and basic training is done in the lab situation. So this is again going to help us train people so they can do a better job. There are lots of different guidelines, and I think with guidelines and with training protocols, we definitely will improve the way we approach consent and assess our outcomes. Lasers, I'm not going to go into details. We have heard about different lasers. We have heard about TFL and holmium laser and different aspects of laser technique, technology, handling, fiber choice. And essentially, this is all going to define the endourologists of tomorrow. Pressure, again, we have heard from Dr. Vineet about pressure. This is just a common language. 0.7 millimeters of mercury is 1 centimeter of water. And we all like to talk in terms of centimeters of water because we understand it a little bit better. What is normal pressure? 12 to 15 centimeters of water. And essentially, I think in modern day endourology, access sheets, especially if they're bendable and with suction, will help avoid high pressures. Mini PCNL, again, with purging and vacuum-assisted devices. But we need better and intelligent ways of measuring it, and hopefully they're coming in future. This is one of the internal pressure measurements using a Comet 2, which is a vascular wire. And when we looked at in this study with 430 pressure traces, 6 developed postoperative sepsis, but they all had a pressure higher than 80 millimeters of mercury. So maybe somewhere around there is a threshold. Below that, there was no sepsis in all of these patients. And I think there is definitely a relationship, as has been shown in so many studies, between pressure and sepsis postoperatively. This is a video just showing the LithoView Elite, which is the scope that can measure the pressure, and you can see the pressure going up as you go up. And again, the preliminary study shows that we underestimate the importance of pressure, or that the pressure can go really high with some of these things. But with suction, I think the value of pressure measurement is likely to go down. Now, digital technology actually revolutionized the way we did stones, the way we did endourology, and we saved time. But now, over a period of time, we have got not just digital technology, but smaller scopes with better irrigation, slimmer sheets, which means less stenting preoperatively, more primary ureteroscopy, less post-op stenting, and the scopes are readily available. So you're not wasting your theater slots. And PUSEN, obviously, one of the early movers in the 7.5 French, But as Vineet said, there are lots more players at this day and age. Looking at the access sheet and cross-section, Dr. Wang spoke about it, how there's better return of fluid. So there's lower pressure problems and better visibility. Looking at where would I use a single-use scope? I think for the lower pole stone, for larger renal stone, in anatomical issues, previous sepsis, this is where I tend to use it. And actually, there are no more than 59 flexible ureteroscopes that have been assessed in this paper. What about a hybrid model? I think that is probably where we'll go, because there's a cost balance between reusable and single use. And in this paper, it showed very clearly that having a hybrid model, which is probably the way forward, you can actually increase the longevity of your reusable scopes, as well as getting the best of single use, both in terms of outcomes as well as training. Endoscopic combined intrarenal surgery is the future. We know that because increasingly we understand that better, and actually we can do it better. And for complex stones, I think this is a good way forward. Mobile health apps in endourology, I think, again, this is going to be very good for patient counseling, especially the fluid tracker apps in terms of minimizing stone recurrences and primary prevention. And this is something that is increasingly being used, and I think will be a way forward in future. Robotic intrarenal surgery, again, there's a lot of robots compared to previously. There are lots of studies. I think it's probably not ready for prime time, mainly because of the cost and the setup time, etc., etc. But I think in time, hopefully, as they get better, the use will increase, especially if the cost comes down. Pediatric stones have really revolutionized with smaller scopes, with suction, better lasers, and this is something with PCNLs, with better lasers, instrument sizes, and the use of fluoroless technology. And again, this is something that is going to continue to evolve, and it is now a part of the guidelines also. We briefly mentioned, Dr. Wang, about the intervention. Why do we need suction? I think that one of the main aspects is to get better stone-free rates, because if you don't do it, if you have residual fragments, it's only a matter of time before half of the patients with over 4 mm stone need intervention, or a disease progression in 9 out of 10 patients. So larger fragments will require intervention, and using these suction devices will get better stone-free rates. What about guidelines? Initially, till 2-3 years ago, there was no consensus on follow-up, and we didn't know, and that's why we looked into it, because there was a lack of evidence. And now we've got a follow-up protocol, if you're not aware, from this year, about what protocol in terms of imaging and in terms of metabolic treatment we should use for patients, and at what frequency, depending on their risk strategy. Simulation in the world of AI. So AI has had a huge leap, and I think it's going to continue to grow. This is just a role of simulation, which is again going to help with training, a role of simulation in both AI-related PCNL and ureteroscopy, as well as in shockwave lithotripsy, because again, this will probably help us predict the outcomes and select patients better, hopefully to minimize complications. What about PCNL? Again, using AI, we were able to look at stone-free status. And again, this is something that can be used in a better predictive model. We can also use machine learning and AI to predict urosepsis. This was a study in 9 high-volume centers where you had 2 groups, one who went to ICU and one who did not. And using this model, we were able to predict and come up with algorithm on which patients are likely to need ICU admission. And again, I think it shows the power of AI going forward. We've used the same in the BAUS large PCNL database in predicting post-PCNL transfusion. Fluoroless is here, and fluoroless should be the way forward, where we minimize radiation. And this was shown very beautifully on where you would use, and in most other cases, you probably don't need to use it. But equally, I would use it as a backup. I don't want to start with no X-ray when you're doing a procedure. You should have it, but you should use it either sparingly or none at all. And in this, we have just shown what steps you can do prior to surgery, what measures you can do during and after surgery to decrease the use of radiation. And in fact, the guidelines also say that you can actually safely, in experienced hands, perform with the fluoroless technique, especially when the anatomy is not a challenge. Looking at the suction, we have already heard 2 beautiful talks about different suction devices and using both the scope suction and the sheet suction. And this is something we'll see more of both in ureteroscopy and in PCNL. And in PCNL, again, you have different ways of suctioning, and these all seem to improve stone-free rate and perhaps reduce complications, as Vineet showed. So what else? I think that we need a checklist tool for some of these things to standardize the outcomes, and these are come. We should adopt them. Perhaps there's a role of genomics to see gene-related risk factors, especially when the hereditary stone disease happen. Perhaps we can look at the papillary configuration through the ureteroscope to see and hopefully predict use of biomarkers for prognosis of kidney stones, again, to see the recurrence rate and who is going to recur, and the role of temperature and pressure measurement, which we have heard about already. What about the outcomes between stone treatment and recurrent urinary tract infections? I think we underestimate the power of stone-free rate, and increasingly we should offer ureteroscopy endourology in patients with recurrent UTIs and stones, because they will have a good infection-free rate after stone clearance. Decision-making, quality of life, and PROMs are going to be increasingly used as a measure of your outcomes, which we currently don't in endourology. Of course, we use that regularly in cancer, but not in endo. And I think this is something that should have a wider adoption. Looking at guidelines, now we're just going to come out with stone burden rather than stone size. And the pediatric outcomes show, based on the work we have done, that flexible ureteroscopy is actually perhaps slightly better than lithotripsy for pediatrics. And this is something that is going to improve. So what do I think the future should be? Smallest scope, least invasive, dust and suction, temperature, pressure monitoring, AI predictive outcome with no recurrence. And that will make me really happy. So we have got the knowledge, but we now also have the technology to give you the best possible outcome. And this is where we are heading. Thank you so much for listening to this one. And with that in mind, given that we are slightly behind schedule, if you have questions, please, my colleagues will try and answer them on the chat box. I'm going to go to the last talk, which is about the clinical application of suction, and share some cases. And at the time, all my panelists, please, if you want to ask questions or have a discussion, please feel free to. So I think we have already heard two nice talks about suction. I'm going to show you a couple of clinical cases. And suction could be through the sheath or through the PUSEN scope, which I have used now on a few cases. And I'm going to just share with you the parts of it. You've got, so this is a video I'm going to just play and talk over. So you've got the fixed laser port, which I quite like. Then you've got this is the fixed laser port, and you've got this very nice button that you can use for suctioning. And it's a single channel, but the suctioning and the fluid goes in and out. And I think with this mechanism, it's quite intuitive and it's quite nice in clinical use. And the port of the suctioning port, you can change it whichever way you want. Now, what are the main advantages apart from the advantages of a small scope of quality, portability, recordability? You have an integrated suction with this. What does that mean? This is what it means. When you look at it, you can maneuver it easily. You can press the button and you can see the suctioning happening real time. And you know, all this worry about negative suction and are you going to cause bleeding, etc. I've now done about 7 cases and I've not seen it in any of them. I don't think that's a big worry, really. So where are the clinical applications? So this is the first case. It was a 2.1 centimeter stone with recurrent UTIs. And the whole objective was to fragment and suck the debris, minimize operative time, and lower intrarenal pressure. And let's see if we achieve that. So this is a real time now case, obviously minimized to a couple of minutes. So normally when you do this laser fragmentation, you have this dust which obscures the vision. But with intermittent suction, you can carry on without waiting, because while the fluid is going and while you do intermittent suctions, the view keeps getting better. So you're not having to wait for the view to clear. In the same breath, you can continue lasering for longer because you're not worried about temperature. And the pressure, again, because you're using suction, as Vineet showed, you don't have to worry about pressure. So what does it mean overall? I think it shortens the operative time. You are less worried about temperature and pressure as you're doing the fragmentation. And I think that is the key. So overall, what I would have expected to take at least an hour, maybe slightly less, for the 2.1 centimeter stone, in this particular case, it took me about 32 minutes to do from the beginning to the end. And I think this is the power of suction. So what is the downside, if any? I think you need to have more irrigation fluid, because as you're sucking, you need to have fluid. So you need to be prepared for that. I still think we don't fully understand the optimal values of suction and so on. And that is something that in time we will understand better. And here again, normally when you do this, you have some dust and debris. But because I'm using intermittent suction, the view completely clears. I'm not having to stop and start, which is what you very often have to do. After you finish, is it good in extracting fragments? I don't think with the current system, unless the channel is bigger, we can extract fragments. But the fine dust particle, you will see that you can extract that. That comes along. But I don't think with the given channel currently that we have in the small scope, you can extract fragments. So you will see here, as we come out, some of the dust and some of the particles will get sucked, but not really the fragments. If you want to do fragment extraction, you need a bigger channel, either through the scope, which is slightly bigger, or through the sheath. So let's have a look at the second case, patient which is young but known to have mid-ureteric stenosis with ballooning before, with a small lower pole stone. And the idea was to overcome the structure with a small caliber scope and minimize operative time. So let's see how we did. So this is the first where you can see a very tight, the wire has just gone about. So I used the 7.5 again with suction. And the idea was to do an endopallotomy, which we did to get the scope in. So again, an advantage with a smaller scope. Once you did that, you would see there's a lot of debris in the kidney, as you'd expect, because of the narrowing. With a suction, normally what you would have used a syringe or something like that. With a suction, it was easy to go in and clear, as you can see here. So again, there's a lot of floating debris. With a suction, it was easy to clear. So it avoids you syringing and so on. Once you did that and decompress the kidney, you will see the stone in the lower pool. And then you can go and treat the lower pool stone as you would normally do with your laser, any laser. Once you have treated that, so here you can see we're just clearing all the debris. And now this is the stone treatment. Break the stone. Interestingly, although as I said, the stone doesn't get captured, you can't really suck the fragment out, but you can move the fragment just using the power of suction. You'll see at the end that once I've broken it, I have used the suction to move a fragment, a small fragment, but to move a fragment. Obviously, I didn't want to bring it all the way out, but you can see that the fragment gets sucked at the end of the scope, and you can actually move it to some extent. So, you know, the power of suction can help with this. So what are the first impressions I have? I think it's a great scope with the advantage of suction, excellent flexibility and maneuverability, good vision, and suctioning allows you to clear the debris, not fragments, but debris, but maintain a good quality of vision. And the fragment retrieval is perhaps easier, but you need a slightly bigger channel for that. Now, coming to the scope, the sheath suction. So this is a 2 centimeter low pull stone. It's one of the patients who have contributed to the Vineet study. And as Vineet has showed, the deflection is really quite good. Patient wasn't pre-stented. So this is a different case, which was an encrusted stent. Before I go to show you that case, you can see there's a lot of debris and dust. And actually, once you have done it, normally for that quantity of debris and dust, you would expect the stent to drain it. You will not be able to suck it out because it's too much. But with a suction scoop, again, you have with a suction sheath, you have the sheath all the way, and you will see at the end, once you have broken it down, you can move the sheath to wherever you want to, and it drains beautifully. And again, that is really good because especially with these matrixy type stones, where you have a lot of sludge, where you have a lot of debris, you can just drain it very, very easily. So for some of these things, obviously come to the hilt and you can go back again and you keep doing it. I have to say, I'm still not fully optimized with what is ideal because it depends on patient to patient about what is the ideal suction, and hopefully we will get there. And this is the case that I was telling you about low pull stone. You can see, as Vineet showed, you can bend the whole thing, break it. So we're using a TFL here, break the stone, and at the end, the fragments comes out very easily without any problems through the sheath, applying the suction. And in fact, even, you know, decent sized fragments, which you would otherwise basket. So there was a question in the Q&A, would you use suction or basket? To my mind, use whatever does the job. A lot of these fragments suction will be able to, but sometimes If it's stuck on the mucosal or if it's with a bit of clot, you might have to use a basket to actually remove it. But as you can see here, the fragments will come out nicely, and lots of fragments coming out. Hard fragments, you come out all the way and then you go back in. And this way you can really, and we did do a CT Vineet the next day and the patient was stone free. So actually, I do think that when you just see it on the internet and when on the Twitter, you're like, well, maybe, you know, is it too good to be true? It is actually quite good. It is too good to be true, but it is a reality. So is there any questions from the panel? And the patient was stone free. I did leave a stent, although I was tempted not to, but I thought, well, you know, in the first few cases, we should leave it, but hopefully I'll get bolder as time goes on. Any questions from the audience? I'll quickly scan the Q&A to see there is a few questions from the same person, but is there any questions from Vineet, Wang or Sylvia?
Do you think having a double channel for direct in-scope suction may be the best way forward for that concept?
You know, Vineet, I think the small scope offers a lot. And if you have the size which is increased, I think you take away quite a big element of the small scope personally. But I do think that there is a role for dual suction, not together, because that will create a big negative pressure. But while you're treating the stone, you use the scope suction. Once the stone is treated, to remove the fragments, you use a sheath suction. And with a combination, but what you're suggesting perhaps will do the same job. But I think because the channel is smaller that way, you may not be able to get bigger fragments. But I think there is a role for dual suction. To do the stone, you just use the suction through the scope. At the end, to remove fragments, you use suction through the sheath. And I think that probably will be the best compromise in the way forward.
Thank you very much, Bhaskar, for sharing with us this very interesting video. I have a question for you. Do you have any experience with bleeding after too much suction during flexible ureteroscopy? And what do you do if you have some bleeding during the procedure?
So it's a very good question, Sylvia. I think this is where I think we have not optimized the sheath suction. We need better optimization. So I always I never keep it fully open all the time. So even when I'm using suction, I'll use intermittent suction. So with a Cleopatra, you've got a hook, you know, I close it. I do not use it all the time. So when the kidney is full, I will go close to it, I'll suck. And when it's sucked out, I will again close the suction and fill it, let it fill up. So I've not had bleeding problems, but in theory, if that happens, just like any bleeding, it will settle down as the kidney opens up. There will be some clot and you can mop the clot out with a basket. So I personally, I don't think you have to be careful that you don't overdo it, that you're not using it all the time. But I think as with practice, we will all improve our technique.
Thank you, Bhaskar.
May I just add to that, Dr. Sylvia?
Please do, Vineet. You have a lot of experience, so please do.
That was a great question and very rightfully so. I think what we should make the audience also understand, the sheath does not cause any bleeding because the sheaths are really good quality. When you have too much suction, you have a decompression hematuria because either you've over-distended the system or you have sucked the mucosas too much. So you have to balance that irrigation and suction, which Professor Bhaskar rightfully said, you have to have more irrigation. And we are trying to optimize what are the correct values of irrigation and suction. So start with a low grade suction and then build it up in the end. Don't build it up right in the beginning because I think you're absolutely right. What is interesting is if you actually have a blood clot, you can use the sheath to aspirate it out. That kind of helps too.
Yeah.
Thank you.
Dr. Wang, any last comments from you?
No, I think you give us a very excellent speech and very perfect cases to show how good was this new tools to us to reach our goal of clear every stone within the kidney. Thank you.
Thank you so much. And thank you again to all the participants. Anonymous attendee, I know you've got more questions. David, Mohammed, and Parimal, thank you for your questions. I hope we have answered some of them in the discussion. And thank you again to PUSEN for this wonderful webinar and something which will start a string of webinars on suction and new concepts as it develops. Thank you to Dr.
Professor
Vineet,
Somani.
Frank, and Sylvia. Yes, Ricardo.
May I have just 1 minute? As a
Please.
PUSEN representative, I would like to express our really sincere gratitude to you since the first day, now that we talk about this webinar, for your availability and professionalism, for the work behind before today. Plus, thanks also to your colleagues, Dr. Gawar, Dr. Proietti, Dr. Wong, for your availability to attend our webinar. And at last but not least, of course, all the attendees, and we are really looking forward to see you all during our next webinar that hopefully will be already at the beginning of next year. Okay. Thank you very
everyone,
much.
and have a good
Thank
new
you.
year. Thank you.
Thank you.
And Christmas.
Yeah, thank you.
Bye.
Bye.
Bye all.
Bye. Bye.
Bye.
Bye
Thank
all.
you so much.